Hello everyone. Today we'll present a series of lectures titled ABC Vestibular. So we'll start by part 1. The best way to develop a foundation of knowledge in any field is to understand the historical development in that field. Robert Pallo, professor of neurology at University of California in the United States, he has authored a nice book. It's called Vertigo, Five Physicians, Scientists, and the Quest for a Cure. And a significant part of the information shared in this presentation is based on the information in that book. So let's start by the word of vertigo. In everyday English, vertigo is often misused in a non-specific manner, referred to a dizzy, confused mind, such as disoriented sensations that many normal people experience with heights, made famous in the Alfred Hitchcock movie Vertigo. The sense of balance was one of the first sensory systems to emerge in evolution, but it was also last to be discovered. Gallen 129 to 217, the standard human anatomy reference for 1,300 years. Interestingly, he never dissected a human body until 1961. The symptoms of vertigo was attributed to cerebral condition, a disorder thought to result from overfilling of blood vessels in the brain. This is what has been mentioned by Gallen, or the explanation for vertigo was promoted by Gallen, and unfortunately it survived like 1,000 years or more. And the treatment consisted of bleeding, leashing, cupping, and purging, which are hard to withstand regimens. So unfortunately, that misconception that is vertigo and dizziness is caused by cerebral condition, mentioned by Gallen, it survived for many decades, and for a long time it was just a belief. That's unfortunately, and based on that concept, the treatment was aggressive and hard to withstand, and maybe more dangerous and more harmful for the patient than the vertigo itself. Antonio Scarpa, all of us are familiar with Scarpa's ganglion in the vestibular nerve, and he's one of the genius scientists contributed to the neurology field. Scarpa entered the University of Padua at 15 years age, graduated with honor at the age of 19 years, published his first work at 20 years ago, and it was at 20 years age, and it was titled Anatomical Observations on the Structure of the Round Window of the Ear or Second Tympanium. Interestingly, as an incredible and questionable act of homage to the great scientist, the head of the great anatomist was removed and exhibited in the Institute of Anatomy, and the head is still exhibited at one of the museums belonging to the University of Pavia. Scarpa draws inner ear structures with the help of Andreoni, and it was mentioned that he locked Andreoni in his room until the illustrations were complete. And if you look here, you find really it doesn't differ much from the current illustrations we use in teaching or learning about the inner ear. Scientists thought that semicircular canals help in sound localization, and because of this, the vestibular system named on the anatomical basis, because at the beginning, the scientists and anatomists, and they didn't know what is the function of the semicircular canals, but because of they are perpendicular to each other and in three perpendicular planes, scientists thought that it might be helpful in localization of the sound. The auditory system is based on its function or its function, but the vestibular system is named based on its anatomy. So, because at the beginning the scientists didn't know what is the function of the semicircular canals. Jane Bear Florence, and most of you are familiar with the name Florence because of the Ewald-Florence law. He's one of the major contributors to the field. He's a French physician scientist, made the first experimental observation on the function of the vestibular labyrinth by removing each semicircular canal in pigeons. After the semicircular canal was cut, he found anomalous head movement in pigeons. Hearing was not affected when he cut the nerve fibers to these organs, but it was discontinued when he cut the basilar papilla. Basilar papilla is the basilar membrane of the cochlea. He observed that selective ablation of semicircular canal makes the animal head and body tended to move in the plane of the damaged canal. For example, damage to the posterior canal, animal fall backwards. Damage of the anterior canal, animal falls forwards. Damage of the horizontal canal, animal turned around the vertical axis. He proved that the cochlea is the only inner ear part which is involved in hearing. What is the meaning of nystagmus? In this image, you can watch this is abnormal head and body movement of the pigeon from after selective removal of the semicircular canals. So the origin of the word nystagmus in the early 19th century from the Greek nystagmos, which it means nodding or drowsiness, from nostazion, which it means nod or be sleepy. So observe, if you are sleepy, your head slowly go down, then you get alert, then a correction fast phase occurs. So slow down, then a correction fast phase. And that is the origin of the word nystagmus. So it's accurately represent the slow phase, then the fast corrective fast phase. Prosper Ménière, and everyone is familiar with Prosper Ménière. He's very well known. He was the first to note and report that patient with damage to the inner ear often had vertigo and hearing loss. As a director of a large deaf-mute institute in Paris, it wasn't difficult to understand how Prosper Ménière concluded that vertigo results from diseases of the inner ear. He undoubtedly saw many patients with the combination of vertigo and deafness. What was difficult, however, is to appreciate how controversial this concept. We mentioned that is the Galen concept, that is vertigo caused by cerebral congestion, have survived for many centuries and like 1,000 or more years. So it was like a belief, it was like a fixed belief. So it was really very controversial that is a new concept will be presented. And that was a big challenge for Prosper Ménière. At that time, the role of the inner ear as an organ of hearing was known, but its role in balance and orientation was completely unknown. Ménière noted that patients with vertigo and associated hearing loss often have a benign course, and aggressive treatment such as bleeding can be more dangerous than the underlying disease. In 1961, this was considered heretical. Vertigo originates from the inner ear, and here is the case scenario, very nice case scenario. A young girl who had journeyed by night in winter on the box seat of a coach. During the time of her catamania, which is the menses period, became, as a result of the severe cold, completely and suddenly deaf in one ear, admitted because of continuous vertigo and vomiting, but unfortunately this supervened on the fifth day. At autopsy, Menier found that the brain and spinal cord were completely normal, but found bloody exudate filling the semicircular canals. Based on this single case, he established the correlation of vertigo to the inner ear. The case was most likely acute leukemia with hemorrhage in the inner ear. Until 1950s, Meniere disease was thought to be caused by hemorrhage in the inner ear. Meniere presented his finding in 1861. He was 61 years old on January 8th in front of the Imperial Academy of Medicine, and he presented a talk titled "Particular Kind of Severe Hearing Loss Resulting from a Lesion of the Inner Ear." He didn't mention vertigo or dizziness. You can imagine how was challenging for him to bring the new concept. The full paper published later at the same year, a report on the lesion of the inner ear giving rise to symptoms of cerebral congestion of apoplectic type, still using the term of cerebral congestion because it wasn't easy to introduce a new concept. First case of Meniere's disease, and that's another very inspiring case scenario, and you can listen to the very meticulous and very precise description of the text. A healthy young man would experience suddenly, without apparent cause, which it means not triggered and it means spontaneous, vertigo, nausea, vomiting, a condition of indescribable stress, drained his strength. His face pale and bathed with sweat proclaimed approach collapse. Lying on his back, he couldn't open his eyes without seeing the object around him whirling in space. The slightest movement of the head increased the vertigo and the nausea. Vomiting started again as soon as the patient tried to change the position. The patient then began noticing loud noises in his ears, along with decreased hearing, first in one ear and then in both ears. Based on these symptoms, Meniere concluded that association of vertigo, tinnitus, and hearing loss were due to single disease. Meniere and migraine. Meniere himself has migraine. Meniere in 1961 noted that people with migraine often had symptoms similar to those of the young man. And he reported that I don't hesitate to regard these migraines as dependent upon a lesion of the inner ear. They are accompanied by noises, by vertigo, and by gradual diminution of hearing, and most often their deafness resists all methods of treatment. So he believed that is the migraine comes from a disorder or a dysfunction in the inner ear. That's not accurate, but it just brings to you the idea of that migraine can present similarly to Meniere's disease. And this you should be kept in mind. Meniere said physician patients are more observant of their symptoms. They give very accurate clinical history. And maybe this is right for some of the physician patients. And for your knowledge, the first description of oscillopsia made by a physician. So he accurately described the symptoms of oscillopsia. But on the contrary, Ballo said physicians are the worst historian as they tend to interpret rather than describe their symptoms. And this is also correct to some extent. Prosper Meniere, he brought some golden statements. First one, if the physician has the patient interest at heart, he will be willing to consider new ideas and look for new answers. Let us give thanks to seeking spirits, to those with initiative. who raise questions of interest, stimulate active researches, provoke opposition, because in a word, science gains and humanity applauds. So it's really great wisdom that is putting the patient interest and at heart. We should look for the new advances in science and the new ideas, and we adapt those which are proved to be true or to be correct to our practice for the sake of better service of our patients. And here is the appreciation also of the researchers who explore the new ideas, who do the research, put the research questions, do the experiments, and do the discussion. Discussions is very important, even the opposition. Even the opposition that's really enrich the literature and the knowledge, and that's brainstorm the thoughts, which is helpful for the patient and helpful for the clinicians. So it's really very wise statements. Minier wrote and published in the Gazette Medical in 1961, so ABCDEF articles, right up until the day before his unexpected death on 7 February 1961 due to influenza pneumonia. Joseph Breuer. Although Joseph Breuer is probably best known for his work with Sigmund Freud on hysteria, he's been the most productive part of his scientific career working on the vestibular receptors of the inner ear. With the physicist Ernest Mach, he developed the Mach-Breuer theory of semicircular canal function. He was the first to recognize that nystagmus resulted from endolymph flow within the semicircular canals, and that is the ambulatory nerve of a single canal could sense endolymph flow in both directions. In 1874, his basic premise was that the semicircular canal senses angular movement of the head by movement of the fluid, which is the endolymph within them. The endolymph moves relative to the walls of the canals because of the inertia. Because the three semicircular canals are approximately at right angles to each other, the canal sense movement in all possible planes. Within each semicircular canal, the sensory receptor is located in a bulbous enlargement called the ampulla. And here is a drawing of the crest ambularis of the semicircular canal. In dissecting the semicircular canals of Paredes, Breuer noted neural endings leading into the ampulla and microscopic hairs extending into the endolymph from bicular epithelial cells at the base. And you can determine the similarity between the drawing by Breuer and the current drawing of the ampulla of the semicircular canal. By carefully studying the anatomy of the macules of fish, reptiles, and birds, he concluded that linear head displacement or tilt causes the otolithic membrane to slip, bending the hair that project it into it and thereby stimulating the underlying sensory receptors. His shear theory of hair cell stimulation is a standard in modern textbooks of vestibular physiology. So Breuer was the one who presented the shear theory, which is valid until now. Purkinje created the world's first independent department of physiology and the first official physiological laboratory known as the Physiological Institute. His contribution to the physiology of vision, the oculomotor, and the vestibular system as well recognized. He described optokinetic nystagmus and optokinetic after nystagmus, and by use of a rotary chair explained the movement after effects as habituation of the gaze motor system. In these times, rotary chairs and centrifuges were used in the treatment of psychiatric patients. These merry-go-rounds, rotary chair, It has been used as a treatment for psychiatric patients. Ernest Mach, who's a physicist and philosopher. Ernest Mach was also born in Bohemia in 1838, and in 1875 he published this famous book, Fundamental of the Theory of Motion Perception. His experiments were mostly psychophysical and included measurement of thresholds and visual vestibular interaction. Using a revolving chair, Ernest Mach, as well as Joseph Breuer and Alexander Brown, all suggested that the parameter that is sensed during rotation is acceleration, and they strongly supported the hypothesis that sensory organ is the labyrinth. Ernest Mach, and he was in a train, and there was on the train was going around a corner, and he felt a tilt, and he tried to explain his feeling of tilt. So he explained that the otolith organs in the inner ear sense the resultant are of the outward centrifuge acceleration and the downward acceleration due to gravity, and send this signal onto the brain. The brain interprets R as the direction of gravity, which is up and down, leading to the illusion of tilt. Ernest Mach was also born in Bohemia in he also used a rotational chair developed by himself to test his theory on semicircular canal and otolith function. The chair could be centered over the vertical axis so that it just tests the semicircular canals, or it could be moved off-center away from the vertical axis so that both the semicircular canals and the otolith organs were stimulated. In the off-center position or off-axis position, the subject could be turned in any direction or tilted about our horizontal axis. So the concept of off-axis rotation was made by Ernest Mach. Alexander Brown, who's a chemist, he introduced the concept of push-pull or reciprocal mechanism. Alexander Brown published a famous paper on the sense of rotation and the anatomy and physiology of the semicircular canals of the internal ear. In the Journal of Anatomy and Physiology in 1874, he came to conclusion about the function of the labyrinths that are still valid. And he made a mechanical model for the push-pull mechanism. And if you see in that platform with a wheel and with a gas, and there is so if you observe that is here, if the platform is moved clockwise, so the wheel on the right moved in counterclockwise. And if the platform is moved anti-clockwise, so the wheel on the left side moves clockwise. So the semicircular canals in panel B, where the platform is accelerated in a clockwise direction above the central pivot, the wheel to the right moves counterclockwise due to its inertia, stretching the spring and opening the valve so that the flame becomes bright. The wheel to the left cannot move because of the stop. In panel C, the platform accelerates in a counterclockwise direction, and the wheel in the left moves in the clockwise direction, stretching the spring and opening the valve, producing a bright flame. So here there is a flame. So when, and here there is a spring, and where is the gas? So it's actually, this model explains clearly that is semicircular canals respond more to excitation or to stimulation much more than the inhibition. because for the inhibition here, there is a stop of the model. There is a stop. So inhibition is limited, but excitation, it has a more space, or it could be done more. So, and we know this, we know that is excitation can move the basic firing rate from 100 to 400 spikes per second, but the inhibition, it's only from 100 to 0. So there is a limited space for the inhibition, but there is more space for the excitation. So semicircular canals respond more to the stimulation than the inhibition. And it's also presented the push-pull mechanism. So when one canal is stimulated, the other paired canal on the opposite side got inhibited. Ewald, he's a German physiologist, and I'm sure all of you know the Ewald's law, which is most important to understand the vestibular physiology. He make a nice experiment with Ewald's pneumatic hammer. So he make with a small drill, he make an opening in the bony semicircular canal without touching the membranous parts of the semicircular canal, and he bought a plug. That plug included the lumen completely, and he bought another hole, and he bought a plastic tube from a pneumatic hammer with a rubber end, so he can push like a positive pressure and negative pressure. And by this way, he can create like ambulobetal endolymph flow and ambulofugal endolymph flow, and he observes the results of this one. So let's read. Ewald drilled two small openings in the bony wall of the semicircular canal, careful not to injure the membranous canal. He placed a plug completely blocking the lumen of the canal in the opening farthest from the ampulla. He fitted a small cannula with a movable plunger or pneumatic hammer into the second opening between the ampulla and the plug. A rubber bulb attached by a rubber hose drove the hammer forward and backward with compression and relaxation of the bulb. Compression of the bulb caused the endolymph to flow toward the ampulla, which is ambulobetal, and the relaxation caused it to flow away from the ampulla, which is ambulofugal. He put his three laws. So the first law, generated slow face eye movement, is in the direction of the endolymph flow in the plane of the stimulated canal. So each canal generates nystagmus in its plane, especially the slow phase, because slow phases, they are the vestibular movements. They are coming from the vestibular system, but the fast phases, they are saccades. They don't represent the vestibular function. So in all the measures, physiological measures of the vestibular system, we use the slow phases because they are the vestibular ones. Okay, so the first law, generated slow phase eye movement, is in the direction of endolymph flow in the plane of the stimulated canal. Ewald's law, to understand, you can apply them to the BPV. So for example, if you have posterior canal BPV, it will generate upbeating torsional nystagmus. Because of the endolymph flow in the plane of that canal. So the second law, ambulobetal flow is excitatory and ambulofugal flow is inhibitory in the lateral canal. Ambulobetal flow is excitatory and ambulofugal flow is inhibitory in the lateral canal, but the opposite is correct for the vertical canals. So the ambulofugal flow is excitatory and ambulofugal flow is inhibitory in the vertical canals. Okay, so in the literature, sometimes they put this is second law, this is the third law, but there is also a law which is part of the Ewald's law, which is that the semicircular canals response to stimulation is more than their response to inhibition. semicircular canals, the response to stimulation is more than their response to inhibition. So this is also a rule or a law which is very important. So I find that in the literature there is some confusion. Sometimes they put, as it's put here, 1, 2, 3. Sometimes they mix 2 and 3, and they add the last one as a separate item. But these 4 laws are the most important and the basic laws for understanding the vestibular physiology. And to understand them very well, apply them to the BPV. So, like posterior canal BPV, if you understand the generation of nystagmus, that's following the Ewell's law. So in lateral canal we have horizontal nystagmus, and because of stimulation gives more response than inhibition. In geotropic horizontal canal you find that is the stimulated or the affected side, and the geotropic variant of horizontal canal gives more stronger nystagmus than the opposite side, because this is the difference between the excitatory response and the inhibitory response. And we know from the Wells law, we know from the physiology, that is, excitatory responses are more stronger than inhibitory responses in the vestibular system. So Ewell's law is the core physiology of the vestibular system. Everyone must know, everyone must memorize, everyone must try to apply them to understand. The best model for Ewell's law is the PPV. Okay? Thank you very much.